With this, I invite Dr. Anubhav sir for red flag features in diabetic retinopathy. He is a senior VR consultant and surgeon at Giridhara Institute, Cochin.
Thank you, Divya and KSOS for giving this opportunity. So, so as we all know, diabetic retinopathy is the most prevailing retinopathy in India nowadays, and in Kerala, it is 25% of patients are diabetic and having retinopathy, who are diabetic having retinopathy, and it is the leading cause of preventable blindness in our community. So if we see 1 out of 10 patients of diabetic retinopathy will be having vision-threatening retinopathy. This is actually a red flag sign in diabetic retinopathy. What are these red flag signs of vision-threatening diabetic retinopathy? Is a patient with severe NPDR, PDR with early NVE or early vitreous hemorrhage or early traction or CSME. Often visual acuity do not correlate with the severity of this disease in diabetic retinopathy. So I'll be going straight away to the case examples, which can highlight few very important features. So first is the case referred for a glaucoma screening and field examination was normal in both the eyes with the patient. A fundus examination of posterior pole showing very subtle signs of diabetic retinopathy in the posterior pole, vision 6/6, macula normal. Even detailed peripheral examination was not showing a lot of diabetic retinopathy features, but the other thing was clinical feature. The pinching point was history. History was of more 15 years of diabetes with very high blood sugars of HbA1c more than 10.9. So if you are finding very subtle changes, but the systemic parameters are not normal, you should do angiogram, which can show you presence of PDR without much signs of NPDR seen on clinical imaging. So angiogram is at must in such cases, which can give you a very good insight in the presence of advanced diabetic retinopathy. The other one is predominantly peripheral lesions. It's called as PPL lesions, which most of us are listening nowadays. So how are these? Mostly you see, these are seen as large blot hemorrhages in the periphery. If you see such patients, you should always have a suspected of PDR, because if you do angiography, you can see extensive NVs in such patients. And there's a very good paper published by Giridhar Hospital. It has shown that approximately 46% of patients with diabetic retinopathy can have PPL lesion, and out of these PPL lesions, mostly will be hemorrhages or microaneurysms, can be seen in 86% of patients. Other PPL lesions can be venous bleeding, NVE, irmas. So wide field fundus photography itself can be a very good imaging thing instead of going additionally to angiogram to find out these PPL lesion in most of these patients. So PPL lesion are highly suggestive of diabetic retinopathy progression and also associated with increased cardiovascular risk. So you should also have a third eye to see them carefully and send the patient for cardiovascular evaluation. Treatment obviously is pan-retinal photocoagulation, as we are giving for PRP. So this is one more example of 38 years old female with vision of 6/6 and 6. You see hardly fundus posterior pole photo showing anything, macula normal. But if you see peripheral wide field imaging, there's 360-degree TRD all around the macula in the right eye, and the left eye not showing very subtle signs of PDR. But if you see angiogram, both eye having very high risk PDR cases. So in any case of suspicious PDR or subtle signs, you should do further imaging, especially with fundus fluorescence angiogram. These cases, this shows the importance of wide field indirect ophthalmoscopy examination in all cases of diabetic retinopathy, and also importance of doing fluorescent angiography in such cases. So this is another case which came with vision of 6/6 in both eyes, but has complaint of floaters, very subtle vitreous hemorrhage seen in right eye, macular normal, blood sugar were also nearly normal. Angiogram shows extensive NVs all around retina in both the eyes, not only in right eye. So this is also an important scenario in which DFA is an important thing. Other one is featureless retina, where you are not seeing anything in the retina. Vision is also normal. OCT is also normal. This patient has just presence of NVI in right eye, but the IOP was normal of 12. So such patients might end up into NVG, because if you see the DFA, you can see 360-degree massive NVs with PDR signs. So these cases might end up into NVG in future. So all subtle signs, even slit lamp microscopy is very important in such cases. Just seeing patient with dilated pupil and diagnosing retinopathy is not enough. Even undilated pupil examination is important in diabetic patients. And in the case of severe NPDR, where you see extensive hard exudates, and large flame-shaped hemorrhages in both eye retina. Vision is poor because of macular signs. Also, you can see chronic DME with vitreomacular interface ERM formation. And this patient has suspicious PPL lesion. If you see, there are large blot hemorrhages in the periphery in both the eyes. So doing angiography ruled out the presence of PDR. So all patients of severe NPDR, it's always better to do a baseline angiogram to rule out presence of PDR, because most of the patient will have hidden NVEs, especially in severe NPDR type of picture. So in the next scenario is a patient with have a poor anti-VEGF response in diabetic macular DME, diabetic macular edema, where you are given multiple injections but edema is recurring. If you do angiogram, you can see multiple microaneurysms in fovea, which is a very good indicator that giving a focal laser to this perifoveal laser to these leaking microaneurysm along with probably one extra anti-VEGF injection can give very excellent results for long-term sustainability. So patient DME not responding to anti-VEGF is another scenario in which angiogram shows early NPDR changes, but that poor vision is because of significant vitreomacular traction. So these patients will not improve with multiple anti-VEGF injections. You have to do vitreous surgery to remove the vitreomacular traction, which will give the improvement. This patient underwent left eye surgery and vision improved from 6/18 and 10 to 6/9 and 6. Another patient in which there is a, if you see, came with recent decrease in vision left eye of 6/18 and 10, and there was a just foveal detachment is seen in the left eye with a fibrovascular proliferation superior to disc. If we closely observe, there was a shallow SRF seen in inferior nasal quadrant with fibrovascular proliferation superior to disc. You can appreciate these all demarcation, and the fovea was off with the inferior RD. These patients should be immediately taken for vitreous surgery, because if we do the surgery early vitrectomy in these patients, they can have a near normal vision instead of observing them till late and getting a poor visual prognosis. So anti-VEGF should be avoided in advanced case of PDRs and patients with traction or TRDs. Anti-VEGF can be given in these cases, but as a precursor, as an adjunct to the vitreous surgery. Just giving alone anti-VEGF is not good practice for treating advanced PDR changes, because anti-VEGF in PDR and fibroscular proliferation can cause a crunch effect, and can cause a worsening of TRD or traction, as you have seen in this picture. So danger signs are subtle maculopathy with poor vision, presence of NVI, presence of periretinal hemorrhage, and presence of NVEs or NVD on DFA. Early intervention in patient with PDR, especially in patient who has non-resolving vitreous hemorrhage, can result in very good visual outcomes. So patients who are suspected to have high chains of associated diabetic retinopathy are patients who has diabetes more than 10 years of duration, type 2 diabetics, especially with early onset of retinopathy, coexisting systemic morbidities like hypertension, cardiovascular diseases, chronic kidney disease, and stroke. And these patients should be screened timely to detect early retinopathy, and treatment should be given timely. So wide field fundus photography and fluorescein angiography is important for early detection and documentation of all cases, especially vision-threatened diabetic retinopathy patients. Careful peripheral retinal examination is mandatory and should be done in clinics carefully, if possible with imaging in all cases of suspected retinopathy, and refer all patients with suspected vision-threatening diabetic retinopathy for further evaluation and treatment if you have limited resources. Thank you for your kind attention.
Thank you, Anubhav sir, for that referral cues. So if a patient of diabetic retinopathy comes to you, you should see the patient as a whole, not the eye alone. That is most of the common mistake I have seen. Most of the systemic parameters remain unassessed. So what is your take on that, sir? I
say always look for blood sugar, systemic parameter, blood sugar control, which I feel has to be counseled every visit to the patient. HbA1c is the most important systemic parameter for diabetes. Second comes fasting. Random blood sugar and ppbs has not much of role. Additionally, hypertension and renal parameters has to be evaluated, because nephropathy can worsen PDR or normal diabetic retinopathy, or even cause poor response of anti-VEGF in macular edema also. So a patient has to be seen as a whole, not just eye evaluation. And slit lamp examination along with fundus examination, both has to be done in detail. The patient should not be seen just for retina if you are sitting in a retina clinic. Thank you.